morning. First of all, let me thank Dr. Mamta for asking me to be a part of this very interesting course. Now, if you look at it, posterior uveitis, if you divide them in the basis of etiology, they can have infective as well as non-infective causes. Toxoplasma, toxocara, tuberculosis, syphilis, viral infections, candida, nocardia, all of them can be infective causes of posterior uveitis. Whereas sarcoidosis, APMPP, serpiginous choroiditis, punctate inner choroidopathy, VKH, sympathetic ophthalmia, there can be multiple non-infective causes, and it is important to differentiate between the two because your treatment will differ. If you end up not treating the infection, you might end up jeopardizing the eye, and you might not have as good outcomes as you may if you identify the infective etiology. Now, before we move on to some cases, I would just like to basically elucidate upon how these lesions differ or how they can present. Now, if you see, is the mouse working? Yeah. Now, if you see a superficial lesion which is usually obscuring the blood vessels, usually these are retinitis lesions, whereas choroiditis is a deeper lesion and you can usually sometimes trace a blood vessel over the lesion. Similarly, active lesions usually will have ill-defined fussy borders and may have some vitreous haze, whereas lesions, when they start responding, when they start getting treated, they become more well-defined. There are some pigmentary changes which occur and the vitreous haze will regress. Now, if you look at toxoplasma, usually these are lesions which are adjacent to a healed scar. They heal with pigmentation and scarring, and you will usually see vitritis in these cases. Now, how do you differentiate three common lesions, a retinitis lesion, a choroiditis lesion, and a posterior scleritis on the basis of an FFA? And a very easy way to remember that is look at the intensity of hypofluorescence on your FFA and look at the pattern of early hyperfluorescence. So if you look at retinitis, the early hypofluorescence is much more significant as compared to what you see in a choroiditis. Similarly, later on when you see the hyperfluorescence, that is perilesional, that usually happens in a retinitis, whereas the diffuse happens in choroiditis, and in a scleritis you will see multiple pinpoint lesions. Some very common etiologies can be like what you see in this photograph over here, a yellow retinitis lesion, graying of the margins, peripheral granularity. This was a case of a CMV retinitis in a patient who had a non-Hodgkin's lymphoma. You will see this arteriolar sheathing. So these are the signs which you will observe when you look at these patients carefully. Some amount of a central clearing. So you see retinitis, you see arteriolar sheathing, and you can easily make a diagnosis of a CMV retinitis in this case. So this happens in immunocompromised patients. There might be a minimal anterior reaction. And why there is not much of an inflammation in these cases is because these patients are already too immunocompromised to mount an immune response. Similarly, acute retinal necrosis will happen mostly in immunocompetent patients, and you will see confluent areas of retinitis along with intense vitritis. So you will see moderate to severe reactions also. These are located in peripheral retina. They may have a rapid progression, and it's important for us to recognize them and treat these patients. This was a patient who had got extensive peripheral lesions. This is another case of ARN or acute retinal necrosis. Similarly, progressive outer retinal necrosis, now if you look at it carefully, again happens in immunocompromised patients. There may be minimal AC and vitreous inflammation, usually involves the posterior pole, and one very important thing is this perivenular clearing of the retinal opacification, which is classically seen in a PORN lesion. Toxoplasma, again like I said, happens in immunocompetent as well as immunocompromised hosts, frequently involves macula, usually starts adjacent to an old scar, can have an associated inflammatory response. This is another case which we'll discuss with, but if you see this area of multiple preretinal exudates and this ground glass retinitis, think of ocular syphilis also as one of your diagnoses. Posterior retinitis is something which also should be kept in mind, and if you see these sort of lesions in a patient who gives a past history of an infection or a viral infection, then keep that in mind. Moving on to a few cases, but before that, the most important part of all uveitis investigations or all uveitis treatment is a careful history and a careful examination, because that will give you clues to what you are dealing with, and a good history will go a long way in clearing your doubts, in making the way easier. So this is the first case. I have already shown it earlier, but this is something which we are seeing more often and often now in our clinics. So this was a young adult engineer who came to our clinic with just a decrease in vision, and he had a cystoid macular edema. All his initial uveitis investigations were within normal limits. Patient did not want to take systemic steroids, so we ended up giving him an intravitreal Ozurdex. His visual acuity subsequently improved from 2050 to 2020, and he was maintained at 2020 for nearly 2 months. But subsequently when he came, you can see a small lesion over here at 5 weeks time, and now you see this peripheral exudates over here. This is the Ozurdex implant which we saw in the photograph, but you see these multiple small preretinal exudates, and now his vision has started progressing or worsening again. From 2020 it has gone back to 2050. You see these areas of retinitis which have again started developing, and now on an FFA you see again this diffuse leakage over here. Within a span of 1 week, now the patient's vision has become 21-25, and we were perplexed as to what we were dealing with. We thought it's probably a fungal infection which has now occurred because of the intravitreal Ozurdex, but that was not the case. His vitreous tab did not reveal presence of any fungus, and he kept on progressively worsening. But then if you look at it now, look at this perilesional area, this area of central clearing, this retinitis, and these exudates, and these actually are classical of ocular syphilis. So we went back and we took the history again, and now this patient tells us that he had a history of an encounter of unprotected intercourse 1.5 years back. Subsequently, he developed a small lesion over his genital area which was a primary chancre, which healed by itself, and now our idea was pretty clear. When we got him tested, his VDRL though was negative, but this was a learning point. His TPHA titers are positive, and this is a point which I would like to stress upon all the audience. For a case of syphilis, VDRL alone does not suffice. You should ideally get a TPHA done. Non-treponemal tests like TPHA and FTA-ABS have got a sensitivity and specificity of around 95% as compared to VDRL, which only has got around 70%. So an ideal test should be a TPHA for these cases. So we started this patient on crystalline penicillin, and within a span of 1 week his lesion started regressing. His vision improved to 20/60, and at last visit his vision was 20/20, and most of the lesions had gone away. So if you look at this placoid chorioretinitis, this is something which you should keep in mind. Keep syphilis as one of your differentials. So like I already said, treponemal tests like FTA-ABS and TPHA remain positive regardless of the treatment or disease activity, and thus, though they are not used to monitor disease activity, they still help us in diagnosing these cases. In the interest of time, I will move on to the second case. Now this was another similar case. This was a patient who was initially thought of as an optic neuritis, was treated elsewhere as optic neuritis, given IV methylprednisolone and also IV triamcinolone. And when the patient presented to us, subsequently he had also received an IVTA, then he received a posterior subtenon because he was not responding. He had again these characteristic lesions which I had shown in the previous case. His vision in the left eye though had now become no PL. We got him investigated again. His TPHA also came positive, and if you look at his OCT also, you see these lesions at the level of RPE. And 1 week after crystalline penicillin, the lesions in the right eye have started regressing. The visual acuity from 2200 improved to 2030 in the right eye. So the point is, if you see this ground glass retinitis, these multiple exudates, then think of ocular syphilis as one of your differentials. And if you diagnose them and treat them correctly with crystalline penicillin, these patients have got a very good outcome. Again, the last presentation, if you see this ground glass chorioretinitis, this placoid chorioretinitis which was initially described by Dr. Gas, keep these in your mind and you will be able to treat your patients, and these patients respond very well to penicillin. So the treatment is on the lines of neurosyphilis. You treat them with 18 to 24 million units of aqueous crystalline penicillin for nearly 10 to 14 days, and partners of these patients should also be evaluated clinically and serologically and tested accordingly. I will move on to my third case, and that is a 36-year-old lady who presented to us with complaints of gradual decrease in vision since 22 days, had a history of headache and mild throbbing pain in both eyes, and past history of fever. There was no other significant history. Her visual acuity was 2200 in both eyes, and if you look at it, there was a bit of diffuse thickening over here on the B scan, and the FFA revealed this characteristic neurosensory detachment in the right eye with multiple pinpoint leakages. And if you look at the FA and the fundus photograph, it's a clear-cut, simple diagnosis of a VKH, and this patient was treated accordingly. The patient received IV methylprednisolone and subsequently received systemic steroids and immunosuppression. Visual acuity improved to 20/80 in both the eyes, and subsequently the patient vision improved to 20/20 and was on maintenance dose. However, the patient went back to Bengal. When she came back, she gave us a history that she had developed chickenpox in the meanwhile, and her dermatologist had treated her for those lesions. But subsequent to that, while her vision in the right eye was 20/20, in the left eye the vision came down to 21/25, and when she presented to us, we found these areas of whitish lesions in the left eye. And if you look at it, these are confluent lesions in the periphery, and what had happened was what we were dealing with initially as a case of VKH, with a non-infectious disease, has now evolved because of the fact that the patient developed chickenpox. I'll just finish it in a moment. The point is that this patient developed chickenpox, subsequently developed ARN because she was already on steroids and immunosuppression, had to be treated with systemic antivirals also. So the point is that for any patient whom you keep on long-term immunosuppression, if they come with a history of chickenpox, their retina should be evaluated. You should look for presence of any infectious diseases in any patient who is immunocompromised. And if detected earlier, all of these patients have a good outcome, but you need to identify the disease and treat them in time. Thank you.